Hello, I'm Dr. Lane Cook. I'm a psychiatrist from Knoxville, Tennessee, and I am the owner and operator of transcranial magnetic stimulation at TMS of Knoxville, Knoxville's premier transcranial magnetic stimulation clinic for the treatment of depression, and the chief of psychiatry at Cornerstone of Recovery in Louisville, Tennessee, where we treat substance abuse and dual diagnosis patients. This is a continuing medical education talk for the Fall Psychiatric Symposium in the fall of 2018. It is continuing medical education. If you're live, if you're watching this video, there is no CME credit. Sorry about that. So this is about panic and anxiety disorders, meds, and therapy. So let's begin. I am a speaker for Shire and Alkermes, and none of the medications that I'm involved in speaking with appear in this video or presentation, so there is no conflict of interest. And I want to sincerely thank Jerry Freed, LCSW, who is one of Knoxville's best behavioral therapists, and I owe a great deal to him in the therapy aspect of this. And thanks, Jerry. Also, thank you to Ben Harrington of the Mental Health Association of East Tennessee, University of Tennessee, who sponsors it, as well as other sponsors, including Cornerstone, as well as Cliff Tennyson, my friend, and the moderator of the symposium. So here are my objectives. I want to talk to you about identifying people with social anxiety disorder and panic disorder, understanding the biology of each and distinguish those differences, to learn the basics about psychotherapies. And you may be a prescriber and you say, I don't do any psychotherapy, and there's a couple of reasons why you should understand it. One is so that you'll know if you're collaborating with somebody who knows really how to treat these in a cognitive behavioral fashion. And the second is you might want to try out your psychotherapy chops with patients to see if you can't move them along more quickly and more effectively with therapy. And lastly, you might be someplace in a small town or in a mental health center or doing telepsychiatry or whatever, and there really isn't an option to split off the psychotherapy with a psychotherapist such as a clinical psychologist or licensed clinical social worker or licensed professional counselor. So you may have to be doing this yourself. So I've got some simplified versions and examples to talk about it. And I am going to, of course, talk about the medications for these two conditions and their effects upon treatment. So I talked about shy and smothering. So shy has to do with social anxiety disorder. It is the third most common psychiatric disorder after major depressive disorder and alcohol use disorder. And as you can see, the chance of having other psychiatric disorders besides social anxiety are pretty high. You have at least a 54% chance of having another anxiety disorder, 56% of having mood disorder, typically depression. Personality disorder would probably mainly be avoidant, but sometimes a schizoid personality disorder. And again, alcohol is quite common. If you are suffering from panic disorder, you are not alone. There are about 27 million adults experience panic attacks annually. About 7 million, or 3% of the population, will have panic disorder. Women outnumber men about 2.5 to 1. 62% of women and 53% of men with post-traumatic stress disorder have these. But unfortunately, there's a somewhat high relapse rate. After the medication is discontinued, it's 41% the first year, 77% in 3 years, and by year 6, it's about 94%. Now, we can affect that significantly by using different types of psychotherapy or breathing retraining, so there is hope there. So social anxiety disorder statistics from the National comorbidity survey replication back in 2001 to 2003 showed that more females than males get it. Overall, in that huge study, about 7% of people suffer from social anxiety. Sometimes the incidence is thought to be as high as 12% of the population. Now, mainly this is something that affects you in late adolescence to your late 20s, but it can occur younger. And the older you get, the less likely you are to develop this or continue to have this. Fortunately, it does tend to decline with age. According to the Anxiety and Depression Association of America, 36% of people with social anxiety disorder experience symptoms for 10 or more years before seeking help. Actually, 80% of patients never receive care. Now, what is the reason for that? Well, primarily it's because those people don't seek help for it. If you have social anxiety and are afraid of scrutiny, these social interactions, then going to therapy is probably not your foremost interest in life. And another big fear is that you're going to see a therapist and the first thing is going to say is, well, you need to start giving public address speeches and go do embarrassing things, and desensitization is important, but not right off the bat. So, as I said, the lifetime prevalence can be as high as 12%. And if you do receive treatment, it's usually in your late 20s. In panic disorder, if you're in a primary care setting, about a third of people don't receive any treatment. If you do, only about 12% received evidence-based CBT, and 22% an adequate type or dose of medication. And unfortunately, 85% remain symptomatic at 4 to 10 months of follow-up. So here's the Diagnostic Statistical Manual, 5th edition, highlights of panic disorder, and you can read those. Probably the most common symptom is this sensations of shortness of breath or smothering. And this really sets it apart from fear. There are catastrophic thoughts, fears of dying, going crazy, losing control, and all of the adrenaline symptoms, palpitations, pounding heart rate, tachycardia, sweating. And this is what the panic disorder is, that you have at least one of the attacks followed by at least 1 month of one or more of the following: persistent worry about it, worry about the implications, I'm going to die, I'm going to have a heart attack, or change in your behavior, and this is with or without agoraphobia, which is a fear of being away from a supportive environment, not just a fear of outside or the mall. With social anxiety disorder, it's more a fear of social interaction, scrutiny, and what some therapists call the big reveal, that you're going to be revealed and be embarrassed from that. And even though the person recognizes that that fear is unreasonable or excessive, it is still quite distressing. And unfortunately, a big part of it is avoidance. And this is not due to other problems such as substance abuse. So there are self-preservation mechanisms involved in this. With social anxiety and panic, the first three are the same. There's that fight, flight, freeze response to perceived danger, hypervigilance to situational awareness of events that are associated with it, and marked avoidance. Now, they're different here in that with social anxiety, the person is trying to maintain self-esteem through protection from embarrassment, shame, and exposure. Whereas in panic disorder, actually it's the body's attempt to maintain a steady flow of oxygen to the brain, muscles, and body. And in social anxiety, it's recognition of hostile intent through facial expression awareness. And in panic, it's careful monitoring of your acid base and oxygen, carbon dioxide balances in your blood and your tissues. So here's a good teaching slide. All mammals have the fight, flight, or freeze response, and this is to save you. If the grizzly bear is chasing you, your heart is going to beat faster, harder. You're going to pump out adrenaline and cortisol, which is going to go to your liver and break down starch into sugar to give you more fuel. You're going to breathe fast, which is great for running, but it kind of sucks for anxiety. You're going to sweat, so you'll cool off, or you'll be a slippery person. So if somebody tries to fight you, you can slip away. And it is important that blood decreases to your organs and increases to your muscle, and your pressure goes up. So the author gave me permission to include this, and I really like this. This is Grace LeConte's 4 responses to fear. You have that fight, flight, freeze, or you can face it, in which you connect, you defend yourself, and you preserve and mitigate the outcomes. And that's definitely the best strategy, not to disengage or run away. In 1963, there weren't really good treatments for panic attacks. They had been described earlier, and people had noted that they were different from anxiety attacks. And the choices were pretty limited back then. The first 2 benzodiazepines that came on the market were low-potency drugs, Librium and Valium. And they were, and still are, not very good medications for panic disorder because of their low potency and tendency towards sedation. So the other medications that help with anxiety were hydroxyzine, the antihistamine that's still approved for anxiety, meparbamate, which is pretty much gone from the market, which had a lot of toxicity, especially in overdose, phenothiazines, and none of these really worked with panic. He was looking at hospitalized patients, and nothing really helped. Now, the tricyclic antidepressants such as imipramine, amitriptyline, nortriptyline, dazipramine had been around since the 50s, and imipramine was approved in 1959. It's an SNRI, serotonin norepinephrine reuptake inhibitor. Unfortunately, it also hits a bunch of other receptors, such as the adrenergic ones, which makes you kind of dizzy when you stand up because your blood pressure is falling. It can make you, it has a lot of antihistamine properties, which makes you gain weight and be sleepy. It's very anticholinergic, blocks the parasympathetic nervous system, so you get dry mouth, maybe even a little urinary hesitancy. So it's not a great drug compared to our newer drugs, but it is as potent, and serotonin and norepinephrine reuptake inhibitor as our modern ones like venlafaxine or Effexor and Cymbalta or duloxetine. So, and this is Dr. Klein. He's currently 90 years old, distinguished fellow of the American Psychiatric Association. So he was dealing with these people, and some of them had some depressive symptoms, and he thought, well, let me try some imipramine and see if that helps. And lo and behold, it put several of them in remission of their panic, and in fairly rapid fashion, whereas the Thorazine and Mellaril medications like that really didn't. He also described them fairly well, that they were not really interested in therapy. They could be manipulative as far as the reinforcement of their avoidance was concerned. And he was the first to note that many of these patients had pretty significant separation anxiety as children. And so when he found that this imipramine, this tricyclic antidepressant, helped rid these people of panic attacks, he decided to publish that, and that was in 1963. And so that was our first kind of pharmacological probe of panic disorder, showing that this one was really different disorder. So there was some work that came out that in 4 different countries, 4 investigations showed that there was an increase in lactic acid production in people with panic disorder when they exercised. You know, that kind of achy, painful feeling when you work your muscles very hard. It's lactic acid. And so Pitts and McClure in St. Louis decided to see if that was what's causing some of the symptoms of panic disorder. So they did intravenous infusions of sodium lactate, and lo and behold, they discovered that it created panic attacks, and they precipitated those. If you used sodium lactate in people that didn't have a history of panic disorder, nothing happened. So this was our first real kind of biomarker of it. Imipramine was a pharmacological probe. Now we have the first biomarker, and this was published in 1967. So later on, Donald Klein again was looking at the difference between people with panic disorder and people who had been scared to death. Not to death, actually. Say combat veterans who'd been shot at or shelled or dropped from airplanes into combat situations. And these people who had been in life-threatening situations would say, my heart beat real fast, I was very shaky, sweaty, I thought I was going to, vomit or have diarrhea. It was really terrible. And he would ask them, when he was looking at them compared to panic attacks, did you feel short of breath? And they would say, no, I didn't really feel like I was smothering or short of breath. You don't typically have smothering and shortness of breath in fear, but you do in panic. So what he did was he published an article in 1987, and this was the second biological probe and biomarker, and he gave carbon dioxide to people with panic disorder, 5% carbon dioxide to inhale, and they had panic attacks at least 50% of the time. And if you didn't have panic disorder, you didn't have it. So he came up with the false suffocation reflex and looked at, you have to have mechanisms to make sure you've got the flow of oxygen coming into your body, because your brain dies in 5 minutes without it. And so he said maybe there's an abnormality there. He also looked at a very rare condition in children called central congenital hypoventilation syndrome. And what these children did was they had an inadequate suffocation reflex, and they would just go to sleep and die. They would smother. And he wondered if they had anxiety, and then he discovered that there were treatments for it. And this is known as Ondine's curse. Ondine was a beautiful maiden in French mythology whose husband professed his undying love and said that I will love you until my last dying breath. Well, in the myth, she discovered that he was cheating on her, so she said, I'm going to curse you, and as long as you're awake, you can breathe, but the moment you go to sleep, you're going to quit breathing and die. And that was known as Ondine's curse, and this was what was labeled the label for the central congenital hypoventilation syndrome. So it turned out that when he studied these children, the oldest was 16, in measures of anxiety and using asthmatic kids and controls to compare them, the asthmatic kids had the most anxiety than the normal controls, and the Ondine's curse kids really didn't have much anxiety at all. So he said this must be part of anxiety. So let's look at respiration here, and this is what respiration looks like, and here's the terminology. Your total lung capacity, as much as you can breathe, is there. Now there's a residual volume that you never really can breathe out, and that's has to do with the volume that's in your bronchi and your trachea. But your vital capacity, if you take a really deep breath in as much as you can and blow it out as much as you can, that's your vital capacity. Your tidal volume is typically what you breathe in and out in an ordinary day. And so you have this partial pressure of carbon dioxide in the blood. the partial pressure of carbon dioxide in the arterial blood, the end-tidal CO2, which is normally 35 to 45 millimeters of mercury, and there's a way that you can measure your exhaled carbon dioxide called capnometry, and anesthesiologists and anesthetists use this when they have people under general anesthesia. So the smothering is unique in panic disorder. Generalized anxiety doesn't have this, OCD doesn't have this, an isolated phobia doesn't have this. You don't have it in post-traumatic stress disorder unless you're having panic attacks. And so there is this need to normally control the pH or the acid alkaline balance in your blood and your oxygen and carbon dioxide. And what we know is that panic patients have some differences from healthy individuals. They have an increased respiratory rate. They sigh a lot, and the depth of the sigh is higher. They have a slower return to baseline PCO2. Their sigh breaths are 2 times the normal tidal volume, which leads to decreased PCO2. And there's a lower baseline of exhaled PCO2. So in Vollmer's study and a few other studies, they monitored people for 24 hours, 43 panic subjects, and what they found was they captured 13 spontaneous panic attacks in 11 subjects. And it turned out that in the hour before, there were some abnormalities of respiration and cardiac function. There was a imperceptible increase in heart rate. The subject couldn't detect it. But in the last few minutes prior to the onset of the panic attack, the person started breathing more shallowly, and there was a decrease in that tidal volume, you know, the difference between how much you inhale and exhale, and the drop in the partial pressure, the pressure for exhaled carbon dioxide marked the onset of the panic attack. And a lot of times what happens is people stop breathing. They'll hold their breath. They'll breathe out against a closed glottis like that. And the rapid change in exhaled carbon dioxide triggers a sudden decrease in blood pH or the respiratory acidosis, which initiates a compensatory respiratory alkalosis. If you like carbonated beverages, colas, you know that there's a certain bite, and that's the carbonic acid in it, that acidic sting that you get from doing that. So if you have less acid in your blood because you breathed out too much of it, that's going to cause you to hyperventilate and in some cases create that panic attack. So here's healthy breathing in this animation. And here is the person with panic disorder. Their pre-panic breathing is less. They all have a decreased tidal volume. And then what happens is they go into that hyperventilation because you have ion sensing, acid sensing ion channels located in the periaqueductal ductal gray near the vertebral arteries, the arterial supply of the brainstem and the posterior brain. And that begins this cascade in which you become panicky and hyperventilate. In 1991, Deakin-Graeff from the United Kingdom and Brazil had collaborated and came up with a very interesting hypothesis, which I call the kind of the grand unified field theory of panic. And basically they promoted this concept with some pretty good proof that panic disorder is a failure of a panic inhibition system, which is mostly serotonergic in nature. And they pulled all of these together in a wonderful theory, and also an illustration I'll show you in a moment. And that there are serotonergic neurons going through the forebrain, brainstem, and that when these are not operational, they increase the vulnerability to affective and anxiety disorders, including panic disorder. Areas of interest include the Raphe nuclei, which have the cell bodies of the serotonergic neurons, the periaqueductal gray, and that chronic but not acute antidepressants, SSRIs, potentiate the serotonergic inhibition of panic escape that happens with the periaqueductal gray. Now, in addition, it turns out that in the periaqueductal gray, it lies in close proximity to the arteries that supply, mainly the vertebral arteries that supply the posterior part of the brain and the brainstem, and along in these areas they have these particular ion channels called acid-sensitive sodium-potassium ion channels. And these are constantly monitoring for protons, which is basically a hydrogen atom without its electron, which form the main issues involved in the acid portion of the CSF. So remember, what's going on here is that it's more that it's not the oxygen carbon dioxide balance as much as it is how the pH is of the CSF in your blood. And so what they're doing is they're constantly monitoring this. And you remember, if you're breathing out too much carbon dioxide, then you don't have enough in your fluids, and you're more alkaline. And to build it back up, you would be more acidic. So what happens is this promotes the respiratory alkalosis by hyperventilating. There, in the amygdala, there are hormones that have to do with ACTH and corticotropin releasing factor, and they have to do with that fight-flight, with the freezing part. Now, a lot of the serotonin 2A receptor expression in the periaqueductal gray is actually localized to GABAergic neurons, and so this is where the benzos come in, because they work on GABA. And the indirect inhibitory effects on serotonin may actually be in part mediated through GABA. So here is a wonderful drawing showing all of the different pathways, and my picture is closing in over what should be the acid sensing channels down here. And this is the basolateral nucleus of the amygdala, and this is where the acid sensing ion channel is. And it's also where you have the impact of the lactate. Remember, sodium lactate infusion causes panic, and it has to do with the osmotic pressure there. Corticotropin is in the central nucleus of the amygdala, and this is where you have this is where the CO2 in inhalation is going to cause this panic behavior. The serotonergic pathways in blue come up and connect with other areas of the brain, the brainstem, and in the green here is the where the serotonin and the GABAergic interneurons connect with one another, and so this would be where we're getting our benefit from using benzodiazepines for panic, and this is the serotonergic ones, of course, have to do with the use of serotonergic or SNRIs and SSRIs and their benefit with panic disorder. So here's some more evidence for their theory, and they found that you can make antagonists of these acid-sensing ion channel. One of them is made from tarantula venom. And one of the things that happens is if you inhibit this, is that you interfere with the long-term potentiation, which is learning and neuroplasticity. And perhaps this is why you get flashbacks and you get emblazoned memories of your first panic attack. So by activating these channels, you're increasing your learning. And in another one article, they talked about how they're associated with fear conditioning in the amygdala. So there's a lot of these acid sensing ion channels there as well. Now, we've known that you can give SSRIs to people and it helps the depression. And if you need tryptophan to make 5-hydroxytryptamine, and so you can artificially deplete that very quickly by just having the person eat or drink nothing but water and a liquid protein shake that is depleted with tryptophan, so they can't make serotonin. And you can actually counteract the effects of an antidepressant. Let's say somebody is stable on an antidepressant, and you put them on this tryptophan depleting protein shake, and within 24 hours they'll get depressed. Well, lo and behold, you discovered that the same thing happens in panic attacks. And that tryptophan depletion has no effect on controls exposed to carbon dioxide. But if you did that in patients with panic disorder, they had stronger panic attacks, higher levels of subjective anxiety, and more physical symptoms of panic. In other words, they were worse. And if you use the immediate precursor to serotonin, L5-hydroxytryptophan in double-blind fashion, you basically decrease the anxiety panic symptom score. So you can make it worse by depleting it, and you can make it better in panic sufferers by using the precursor 5-hydroxytryptophan. So there are some genes that are associated with it, and they appear to be stronger when early onset panic disorder cases and those with prominent respiratory controls were there. Now, what's interesting, we're going to talk about the anxiety response to fearful or angry faces in social anxiety, and it turned out that one of the alleles was also sensitive to fearful and angry faces. And so we think that this has to do with those acids in